Welcome to the Hand to Shoulder Solution, giving pain the middle finger. I'm Petitto. I'm an occupational therapist and a board-certified hand therapist. I specialize in orthopedic conditions of the fingertips through the shoulder. I want to talk about the basic anatomy and basic mechanics of the hand through the shoulder. Today, I want to talk about the elbow and the forearm, and those are two separate joints. The elbow is actually, there's three joints in the elbow. The forearm is one joint, and that forearm rotates. About the upper extremity in general, the hand through the shoulder is the upper extremity. If this is our very important tool that we use for everything during the day, that tool has to be positioned. So if the hand is optimally healthy and we need to position that where it needs to be and use it appropriately, we rely on the shoulder, the elbow, and the forearm to position that hand, and of course the wrist. The wrist is a joint of joints and encompasses 15 bones, 24 contact surfaces. We'll get that later in a different episode. Now, you can have a great hand, but if you can't position it because your elbow hurts, or if you have a fracture or a broken bone, or any, multiple conditions that would affect placement of the hand, then you really can't use your hand very well. Now, if you have a great forearm, elbow, and shoulder, and you can position it, but your hand is crushed or fractured, or the tendons are severed, if your hand isn't functioning, then great, we can place it there, but we can't use the hand. So anyway, my message is we really need to have it all working. And I always joke with my patients, say, hey, you're only born with two. You need them both. You one hand helps the other. One hand washes the other. One hand holds an object while another hand manipulates or does a task to remove a lid, for example. You need them both working together. So let's start with the skeleton. Let's start with the bones. Let's get into the elbow. So I have a right arm over here, and we'll get to the shoulder blade. We'll get to the ball and socket. And we'll get to the ball and socket later. Right now, let's take a look at the elbow. So the elbow is comprised of the humerus, comes down and meets the ulna. The ulna is the tip of the elbow. So your tip of the elbow is the ulna, which always stays stationary. A part that rotates is the radius. So that radius, when you have your hand palm up, your radius is now parallel with your ulna. When you turn your hand palm down, and this is the right hand, when you turn it palm down, the radius flips over the top of the ulna. When you turn it palm up, comes back. So proximal means close to the body, distal means away from the body. So proximally, you have the head of the radius spinning on the end of the humerus, okay, the arm bone. So we have the arm and the forearm. And then distally toward the wrist, at the wrist, we have the radius rotating around the end of the ulna. So we have our proximal radial ulnar joint and our distal radial ulnar joint. And those need to be working so that way you can position your hand palm down, palm facing downward, or palm facing upward. Who positioned the hand like that? Well, this is the hand to shoulder solution, giving pain the middle finger. And you're really close. I feel like I should name you. How about Mike? That works. Okay. So the elbow, there's three joints. There's where the ulna meets the elbow. Remember the tip of the elbow, and where the radius meets the humerus. Okay, and also where the radius meets the ulna. So remember that area that spins. Now I want to talk about the first condition I have on my list to bring to you, which is a very, very common condition, and that's tennis elbow. And in orthopedics, there's nicknames for many of these conditions. It's really lateral epicondylitis. Itis means inflammation. Lateral epicondyle just explains a body part. Medial is toward the midline of the body. Lateral is away from the midline. So lateral epicondylitis, itis means inflammation. And what the word means is inflammation of the lateral epicondyle. And that is this bony prominence on the thumb side or the outside part. If you feel your elbow, you'll feel a knobby area there, a round bony area. And what that is the anchor point for all of the muscles that do this, and do this, and do this. So those muscles lie against these bones on the back side of the forearm, and they're anchored there. Muscles only pull, they do not push. So on this surface, when they pull, they extend the wrist, they extend the fingers. On the opposite surface, they anchor it in on the inside part of the elbow, and they bend the wrist toward the palm and close the fist. They bend the fingers or flex the fingers. Okay. Now, if there was an anchor point, it wouldn't have an action down here. It would just contract and nothing would happen. But since they're tied in somewhere, now they contract and they extend the wrist and they can extend the fingers. And then there's another one, which we'll talk about later, that contracts and does this. So if a person is doing a lot of, heavy lifting, or, they strain these muscles somehow. I had a patient who his job was to mark trees with a hatchet, and he was marking an X on upwards of 200 trees a day. And he was really severely aggravating this area. What happens is the force of the muscle pulling on the tendon, tensile stress or pulling stress, really aggravates that insertion point or the origin of the muscle. So where it's anchored in there, that actual bone starts to get very inflamed. So if you touch yourself on the outside of your elbow and you're touching that bone and that's really tender, that simply means it's inflamed, it's irritated. Now, moving down a little bit, there's what's called the common extensor tendon. So all of those muscles that do these motions, they converge on one common tendon, and that's the tendon that's anchored into the bone. Okay, so tendons connect muscles to bone, and the tendon also gets inflamed. So remember, itis means inflammation, tendonitis. So you start getting tendonitis. Now, if this goes on for a long time, and this is a good place to note that if you're having the problems and this is going on for a few weeks, don't wait for a few months. The sooner that I can get to your elbow, or any hand therapist can get to your elbow, the better, and we can get this to go away quickly. So if it goes on for a long time, tendonitis turns into tendinosis. And tendinosis is, if you can picture a big wide piece of yarn, and the yarn starts to fray and it starts to get kind of scraggly, the tendon is starting to break down. We can still fix it at that point conservatively, meaning without surgery, but it's a lot more difficult. It's harder on the patient and the therapist. Of course, most importantly, the patient, and it takes longer to get better. So, we don't want to see that. Now, here's something for you. Watch this. So we talked about the muscles that do this, and they do this. They're on the backside of the hand. They're on the backside of the forearm, rather, and they're anchored into that bone on the outside part of your elbow. Now, tight grip also causes a problem here, but you're probably asking, well, why grip? Grip is using these muscles on the opposite side that are tied into the inside part of the elbow, the medial epicondyle. So that this epicondyle, or again, bony prominence, that is the anchor point for those muscles that grip and flex the wrist and turn it palm down. When you grip and you're using those muscles, If your wrist extensors, the ones that are tied in on the outside part of your elbow, were not contracting, you would grip and you would just fall down like this. So with a tight grip, the muscles on both sides have to contract so you don't fall into wrist flexion. So your extensors automatically, and this happens automatic, it's very interesting that the extensors automatically contract to keep everything stable, everything straight, so you can have a good, powerful grip. As a matter of fact, the extensors even activate a little bit extra so you can go into wrist extension. So it physically, mechanically pulls the wrist flexors down tighter so you can have a really tight grip. So here's some basic mechanics. And I really like the mechanics. I have a background in welding and machining and fabricating parts for aircraft. I was stationed on aircraft carriers. That's another episode for another day. But when you make a tight fist, and the wrist moves into extension, and that increases the power of your grip. Now you're pulling really hard on that outside bone that's giving you a problem with the tennis elbow, and also on the inside, where some patients come in, they have tennis elbow and golfer's elbow, which we'll talk about in a few minutes. We'll talk about golfers. So I have patients avoid lifting anything palm down. So when you lift palm down, of course, you're picking up a weight, and in order for you not to fall down this way, those wrist extensors have to contract, and that's really focusing all of the tension on that outside part of the elbow. The best way to lift with tennis elbow is palm up, and I'll demonstrate that to my patients. I will have my patients hold their hand palm up, and I'll push down, and I'll have them resist as hard as they can. Zero pain. Here, one finger, push up against me. Ow, that hurts a lot. They're simply using different muscles that are anchored into different bones, and that's the basic mechanics. Also have to avoid a really tight grip. So when you grip really hard, like I mentioned earlier, that's activating this side so it doesn't fall down into flexion. So avoiding a tight grip and avoiding lifting anything with your palm facing downward. The next best position compared to lifting palm up is lifting in a hammer position. That uses some different muscles. It's not as good as palm up, but lifting everything palm up all of the time, I realize that it's not practical. Sometimes you have to lift like this, but very rarely do we have to lift with our palm facing downward. Now, let's move on to golfer's elbow. And again, there's so many nicknames for conditions in orthopedics: tennis elbow, golfer's elbow, gamekeeper's thumb. But Mike, you're still there. Okay, all right, good. Now, golfer's elbow. The muscles that are in the palmar surface of your forearm, they do this. They flex your wrist and they flex your fingers. And they turn a hand from a palm up position to a palm down position. And again, muscles only pull, they don't push. So, right, Mike? They are anchored in to the inside part of that bone. Where are we? Okay. The medial epicondyle. And that's their anchor point. So when they pull, they move the bottom portion, the end portion, which is the wrist and the fingers, and then they also rotate it palm downward. So it's the opposite with this. We don't want to lift real heavy things palm up. I would have patients try to lift, thumb facing up in more of a hammer position. Of course, try to avoid a tight grip because that's where they're directly anchored in at that point. And we'll talk about some of the treatment techniques a little bit later. Moving on to the next thing at the elbow is cubital tunnel syndrome. So cubital just means elbow, and tunnel, there's tunnels that the nerves pass through when they go through the arm. So all of our nerves, basically it starts at the brain. So at the brain, there's something called the homunculus. Do that at a different time. Brain fell apart. So the brain sends signals to the muscles through the nerves. So we actually have electrical signals traveling through our bodies, and they travel through the nerves, or simply the wiring system for our body. So the wiring system goes both directions. We have sensory nerves. So when we touch things and, we feel a surface, you can close your eyes and put a quarter in your hand and feel it, and you know that that's a quarter. That sensory is traveling from your hand up to the brain. Now there's also, of course, motor. So then the motor nerves send signals to the muscles to contract and move the skeleton. The nerves travel through muscles, and they travel through bones through specific tunnels. Everybody's pretty familiar with the carpal tunnel, but there's other tunnels aside from the carpal tunnel, and one of them is the cubital tunnel. So again, cubital means elbow. This is the right side. So if you feel a knobby or bony prominence on the inside part of your elbow, then you feel the very tip of your elbow. Between those two, which is right here, so there's the tip of the elbow, here's that bony prominence, there's a trough there, there's a tunnel, and it'll feel like a little soft little ditch right there. And people call it the funny bone. And when you hit your funny bone and you feel that zinger, you feel the tingling, sensation, you're actually hitting the nerve. And every nerve also has a name. It's called the ulnar nerve. The nerves are pretty big. They're about the width of a pen or pencil, and thick like a noodle. And they can get compressed through these tunnels. And if you compress a nerve, you start causing numbness and tingling traveling down the location that nerve innervates or plugs into. So as a clinician, if a patient comes in and they're having numbness and tingling on the thumb side of their hand, I know what nerve it is, number one, and then I know possible compression sites, whether it's the neck or shoulder area or carpal tunnel, if it's the thumb side, or if it's the small finger side, is it Guyon's canal next to the carpal tunnel? Now, a lot of people get this cubital tunnel syndrome, pressure on the ulnar nerve that's causing numbness and tingling down this small finger, half of the ring finger. It's actually that precise what areas these nerves innervate or plug into. It's usually caused by people leaning on their elbows on the inside part of the elbow. I treat a lot of truck drivers, snowplow drivers. Up where I live, we get a lot of snow in the winter, and resting on the center console, resting up on the window. I didn't realize how often I touch my inside part of my elbows to my desk chair, and there weren't bolts underneath to take it off, so I took it out in the parking lot and used the Sawzall and just cut the armrests off, and my cubital tunnel syndrome went away. I find myself now resting on my elbows. There's a good technique at home for people. I have my patients rest their forearm on a rolled up towel or something, so the inside part of the elbow is up off of the furniture, so they're not resting on it. There's a lot of other treatment techniques, very specific things that we do in the office, and then we have people do as part of their home program as well, that we'll get into a little bit later. We'll circle back to each condition and talk about how do we treat these things. All right. Now, the next topic I want to talk about is olecranon bursitis. So bursitis, there's that itis again. So remember, tendonitis, itis means inflammation of the tendon. Bursitis, itis means inflammation still, but bursa, what's a bursa? So a bursa sac is usually a little shock absorbing, fluid filled sac. Picture a water balloon. The water balloon, the balloon part of the balloon is living tissue. And that living tissue gets inflamed and irritated, and we just need to calm it down. So picture something that's red, aggravated, swollen, and we need to shrink down the inflammation to decrease the pain. The fluid inside is fluid that's there for its shock absorption, and there's a really flat little bursa sac on the tip of the elbow. And people rest on the desk, on the desk a lot, and or bump it, or maybe somebody fell on it. That can get really big, like the size of a golf ball. For that we have people use a cryotherapy technique of cold running water, just sticking it under the cold running faucet only until it's deeply cold, which studies have shown is better than an ice pack for 10 minutes. It should take 10 to 20 seconds, and literally shrink down the inflammation, and then fabricate a pad or some kind of elbow heel pad donut type of a thing, so that patients are not resting on that at night when they're sleeping, like during the day, or just staying off the tip of that elbow. There is a surgery. They can actually remove the bursa sac, but of course, surgery is always a last resort, and surgeons try to avoid that. And most of the time, we're very successful with therapy. We'll come back to that as well. Triceps tendonitis. So biceps, most of us are familiar with that. The biceps contract, you bend the elbow. Also biceps, here's a piece of gee whiz information. So when the forearm is in a palm down position, the biceps is in a lengthened position, and I'll show you why. The biceps inserts into this radial tuberosity right there. So the tendon, the muscle comes down, it turns into tendon, and it inserts right here into the bone. And when you turn it palm down, now the tendon is hooked underneath. So when the muscle contracts up here, this is the main mover for turning the hand palm up. So it's palm down, biceps is relaxed, and now biceps contracts, pulls on that bone, that knobby piece of bone, and turns the palm up. Also bends the elbow. We have 3 muscles that bend the elbow, and we'll talk about that. But biceps tendonitis, that affects the shoulder. Also, a little less commonly down here lower, where it inserts into that bone I just showed you. That can get very inflamed. Also, patients will go, a common injury is a quick contraction of the muscle, where I think in the last month I had 2 people who they were lifting up something heavy and it slipped, and they went to catch it, and it did a quick force, and they feel and hear a loud pop, and that is the biceps tendon literally rupturing, or pulling. Also, it will just pull out of the hole that it goes into. It will pull out of the bone. Sometimes it can even cause an avulsion fracture, which means it pulls a piece of bone out with it. That's pretty uncommon at that location. But anyway, there's when that happens, folks need surgery. The job of the hand therapist, is to protect the repair, make sure that it doesn't rupture or gap, and to allow that to heal. We put them in a very specific brace that has a hinge. So as the heel and as the tendon can take more tensile or pulling stress on it, we turn the hinge and allow more range of motion out straight. In the clinic, we get them in and put the tendon on slack, turn the forearm to make sure that the structures are not getting tight, because something that connects bone to bone is ligaments. So the ligaments start to shrink. A lot of stuff happens to cause stiffness that can be very, very difficult to get rid of. So the therapist will manipulate the patient's arm in a very safe manner, protecting the repair site and then modifying the home exercise program so that the patient is doing the best things to get themselves better quicker, and then coming to the office about once a week. And it's typically every week we will advance the brace about 10 more degrees to allow more movement. So elbow flexion, bending the elbow, that puts the biceps on slack. Straightening it, now the biceps is all the way straight in a lengthened position. So it's straightening the elbow that we have to do incrementally every week in the clinic that gets adjusted. And then while they're in the clinic, we modify the home exercise program and really advance a few other little details for the patient that they can do for themselves at home. Now, other trauma, olecranon fracture. A lot of people will fall right on the tip of their elbow, and that gets fractured or broken. And that tip of the elbow is part of the ulna, and it makes a C shape right here. If that is allowed to heal in a wrong position, you could have a sloppy joint or an unstable joint. We cannot allow that to happen. So typically, surgeons will place plate and screws and really align that perfectly. Now, we can't just stick them in a cast for 6 weeks. Remember, there's 3 joints. There's 3 joints in the elbow. Humerus to ulna, humerus to radius, radius to ulna. We cannot immobilize that for very long. So I typically, instead of making a cast, what I'll do is I'll fabricate an orthosis or a custom molded split where I make a template, cut out flat stock, mold it to the patient, allows their elbow to bend, and blocks rotation, or depending on the condition and what surgery was performed, a different brace that actually fully immobilizes the elbow and the forearm, keeps the wrists and fingers free, and then they would take it off and do some gentle range of motion. And some really interesting studies were performed to understanding the biomechanics or the mechanics of the skeleton, the musculoskeletal system. When you bend your elbow and simultaneously turn it palm up, like washing your face, that puts less stress on the joints and the muscles. Extending the elbow or straightening the elbow and simultaneously turning it palm down puts less stress on the muscles, versus if you were to just do them segmentally and really isolate different parts, moving them together in a specific motion puts less stress on the healing fracture site. And we'll get into more of that with the that end of the radius. And we can go to that right now, where a common injury is what's called a foosh, a fall on an outstretched hand. And where I live in the wintertime, we get a lot of snow and ice, and a lot of people fall. And a tumble is one thing. If you tumble, okay, that's a little safer than slipping on the ice. When you slip on the ice, your feet come out from under you, and it's a whipping sensation. You get whipped down onto the ground. It's extra force when your feet whip out from under you. You slam down, and when you slam down on an outstretched hand, typically what you hit first is the end of that radius bone. So remember, palm up, radius is parallel with the ulna, palm down. The radius turns over the top, flips over the top of the ulna, and this section hits, it cracks right here, and this end section moves toward the back. That's called a Colles fracture, Colles. Dr. Colles named that. That needs to, if it's fractured and not displaced, meaning if it's fractured but it's still in alignment, then I can fabricate a nice custom brace that can be removed for going in the shower. It can be removed for some light range of motion, or depending on the fracture, we'll put that in a cast. And then as soon as it's healed enough to really get that moving, sooner rather than later, then we do so. If it's a repair, let's say the end of that radius bone is shifted or is displaced, then that needs to be brought back into alignment. A plate and screws needs to be inserted to hold that alignment, and then that's when I would fabricate a custom brace that would stabilize the wrist, take it off, do some gentle range of motion. It starts in 1 to 2 weeks after surgery. So in the old days, we would wait, you'd put everybody in a cast, wait for 6 weeks, and then take them out and do some very difficult, strenuous therapy and get range of motion back. Very, very difficult. Now, with best practices, we realized with the excellent research that has been done, that this can tolerate early range of motion, as early as 1 or 2 weeks after surgery. But there's, as with anything, there's a lot of details. So what kind of, was it fractured in just one nice clean line? Did the fracture line go into the joint surface where the surface articulates or connects with the next upcoming set of bones? That's a consideration for the hand therapist. Was it in multiple pieces? That's called comminution or comminuted fracture. Was that fracture or break in multiple pieces? If it was, that tells me, well, we're going to have to, it's a little more of a tenuous or a delicate situation. We have to wait a little bit longer. I'll still make the same custom brace. We'll hold off our range of motion. We'll move the bigger joints first, like the elbow, and a little bit of the forearm, but really hold off on any significant wrist range of motion. Again, depending on the case, depending on the situation. So that's the distal radius. Back to the biceps, we talked about that end of the biceps rupturing down by the elbow. We feel it and hear that loud pop. The proximal or up closer to the body, the biceps also can rupture at the shoulder. So it's something pretty interesting. Baseball pitchers they'll start having a biceps that starts getting really inflamed. You get the tendonitis, and then that turns into tendinosis. Remember the fraying of the tendon, getting frayed like yarn, and it's just painful, sore. But the second that biceps ruptures and there's a loud pop, the pain fully goes away. The biceps tendon actually travels. There's 2 tendons of the biceps, a long one and a short one. The long one goes up through this groove called the bicipital groove for biceps, and the tendon travels through. It actually inserts on the top of the socket where the of the shoulder, and that is anytime a tendon goes through a joint, that's really asking for trouble. But that starts to fray and breaks. There is a nice surgery for that, where the surgeon will take that tendon, and rather than putting it back through the joint, they drill a little hole and use a bone anchor and put that under pectoralis muscle that inserts over here. And then that gets really nice and secured right into that bone, and they have their biceps function back. If you see that you have a Popeye sign, where you have a big bulge here, your biceps is probably torn, and then the muscle, part of the muscle, gets bulged up. So looking at the biceps, we take off the deltoid, the outside muscle of your shoulder. It's called biceps bi for 2. So that here's the long head of the biceps right here that travels over the head of the humerus, or the ball of the ball and socket, and inserts on the top of the socket. The other head goes up and it inserts on a bony prominence, which is on the front part of the shoulder blade. And that's right there. That's the coracoid process. The name doesn't matter, but just know that when you feel, if you feel the ball of your arm, you can move your arm around and feel where it's moving, and then you can go inward a little bit toward you, where there's a little bony knob right here, and that's where that the other head of the biceps inserts. So there's a short head and a long head, therefore biceps.